We have Alberto Mormile, which will talk about thyroid radiofrequency ablation, the technical principle.
Thank you, Roberto, for a nice invitation, and good afternoon to all of you. Thyroid radiofrequency ablation, only technical principle. What is radiofrequency? Is an alternating electric current oscillating between 200 and 1,200 kilohertz. Radiofrequency is we can place into the lesion a needle or electrode, and radiofrequency is delivered through an electrode. The movement of the ions within the tissue creates frictional heat, and so we can ablate the tissue. We have frictional heating, immediate coagulation necrosis near the needle, and then, over time, with conductive heating, we have a more large area of ablation. This is the same concept. Near the needle, friction, and over time, conductive heat, more large ablation area. Which is the temperature, the optimal temperature to have a coagulation necrosis? Is between 60 to 100 degree. Because if we have 100 to 200 degree, we have desiccation, and over 200 degree carbonization of the tissue. The term of coagulation necrosis has been used to denote irreversible damage of the cells. If temperature exceeds 105 degree, cells are dehydrated and carbonated. These events stop heat and energy dispersion, and we have a reduction of the treatment efficacy. The radiofrequency thermal ablation should ideally induce a prolonged tissue heating with temperature between 60 to 100 in the volume of all the nodule. A lot of years ago, in 1938, Dr. Penn outlined a biohet equation. The original equation is very difficult to understand for a medical doctor like me, as for an engineering or physics, but we have a possibility to have a simplified equation. That is, coagulation necrosis is equal to energy deposited multiplied by local tissue interaction minus heat loss. Energy deposited depends on tissue temperature achieved, duration of heating, and also size of electrode. Local tissue interaction depends on the nature of the target tissue. For example, fibrosis and calcification can alter electrical and thermal conductance of radiofrequency. Heat loss depends on blood flow. This results in perfusion-mediated tissue cooling with reduction of ablation area. It's interesting to see that a single applicator, radiofrequency, laser, or microwave, produce coagulation necrosis in the measure of 1 centimeter to 1.6 millimeters, to 10 milliliters to 60 milliliters in diameter. Okay, so several strategies have been developed in the time with the goal to increase the region of induced coagulation. For example, multiprobe arrays, like with laser, with technical limitation to remain in the same position long time, or multiple application like hook array, but with the difficulty to see all the tip of the umbrella needle. And saline infusion also, but with irregular shape of the area of ablation. And then internally cooled applicator, which I think is the best for radiofrequency. 10 years ago, a thyroid dedicated internal cooled needle was proposed by Dr. Beck. The needle is thin, the point of the needle is active, and into the needle flow ice water moved by a pump. When the radio frequency is switched on, only the point of a needle become, we have it only on the point of a needle. These procedures cause an X-sync effect that remove heat closest to the electrode. We can see. This is the area under curve we can obtain with cooling radiofrequency electrode. That is bigger than conventional radiofrequency electrode, okay? And the area corresponds to the energy deposited in the tissue. And also the distance of the ablation from electrode is bigger with cooling radiofrequency needle than the conventional radiofrequency needle. Some word about the equipment for radiofrequency thermal ablation. There is a generator of radiofrequency and an electric pump, ground pads, and a unipolar needle. Current runs through the body, with the entire body, from the point to the electrode to the ground pads. In patients who have a pacemaker, pregnant woman, or metallic prosthesis, we can use a bipolar electrode. Bipolar electrode add the ground pads into the electrodes in the electrode. So the electricity remain on the point of the needle. Okay, and there are no passage of current along the body. On the generator during the treatment, we can see some important aspect. Ablation is confirmed by the abrupt increase in impedance and by decreased power of radiofrequency. All the parameters are registered on the monitor. When the impedance increase and the power decrease, we can move the needle. If the needle remains fixed, the radiofrequency is switched off to reduce the risk to have carbonization. For all these aspects, I think that now for radiofrequency thermal ablation of the thyroid, the most appropriate ablation is using internal cooled electrode with moving shoot technique and transvisic approach. Thanks for your attention.
Thank you for your nice presentation, which is open to the questions. One question from me: which needle you use? The bipolar needle or the one with the pads?
But
usually, in your routine work.
Usually, we use the unipolar. No, pardon, the unipolar. Bipolar only in particular cases, of course.
Why? Because of the cost of the needle?
No, but because it's the standard needle and is always used, and it's very, very easy to use. Okay. And we haven't complication with the ground pads in our experience.
Other questions?
If I could ask a question, Mario Stan, USA. This has to do with the temperature that you described is reached in the tissue up to 105 Celsius. And there's an ongoing discussion between some of the people performing the procedure, what happens with the thyroid hormone that is released at the time of this tissue destruction. In particular, the more tissue you ablate, is it likely that there's still bioactive hormone that is released, or do you think that is distorted the three-dimensional structure and it becomes inactive?
But I think that in all the thermal ablation, laser, radiofrequency, there is an augmentation of the hormone in the circulation. But in our experience, there is no clinical aspect. No, there is no problem because it's very during one day only. Yes. Yes. Also with laser or I think microwave.
Hi, Alberto. Thank you for the presentation. It's great. A technical question. So when you have a big nodule and you puncture and you start doing the radiofrequency ablation like a fan, no? Sometimes the nodule is big. Is it possible that it's better to do two punctures and do the same fan instead of one? Because when you put the puncture and then you start ablating, sometimes the tissue gets very hard and then you cannot move it freely, the needle.
This question is about not technical aspect, but the treatment aspect. And in my opinion, I prefer to have only one access. Only one access. But of course, it's possible to remove a needle and have another access to have the possibility of an ablation of the entire volume of a nodule, because sometimes the nodule is so bigger that with only one access it's difficult to have a complete ablation of a nodule. Yes, of course. But this is my opinion. I don't know Dr. Valcavio and Dr. Beck was the opinion about the question.
Thank you, Alberto. We move on. Next speaker,